Hey all, welcome back to the Real Life Pharmacology podcast. I'm host pharmacist Eric Christensen. Thank you so much for listening today. As always, go check out the Real Life Pharmacology Top 200 Study Guide. It is a free 31-page PDF on the top 200 drugs. I outline some of the most important things you're going to see in practice, as well as those that show up on board exams and pharmacology exams throughout your career. So go check that out. Take advantage of that. Simply an email will get you access to that. We've also got updates when we have new content available as well. All right, let's get into the drug of the day today. And it is dextroamphetamine and amphetamine combination, amphetamine derivatives. Brand name is Adderall, which it's probably more commonly referred to as. This medication is used primarily, what I see in practice is for ADHD, attention deficit hyperactivity disorder, as well as narcolepsy. Can be used for that as well. In my practice in geriatrics, rarely I have seen it used to basically stimulate energy, combat fatigue. This is absolutely an off-label use in patients who are rehabbing, in elderly patients, that type of thing. I've seen it a few times, don't love seeing it because we've got plenty of potential adverse effects and risks associated with this class, particularly in geriatric patients. But I did want to mention that kind of additional use that I have seen off-label. Mechanistically, how does this combination work, amphetamines and dextroamphetamine? So essentially they are non-catecholamine sympathomimetic amines that promote the release of catecholamines. And okay, what are catecholamines? Well, think dopamine and think norepinephrine. I mean, those are the two primary ones that this medication is essentially going to increase the action of those within the central nervous system, as well as within the rest of the body there as well. So that's the primary action that you can think of: an increase in dopamine, increase in norepinephrine action. And I'll talk a little bit about, that release and how it pertains to adverse effects coming up here. With that said, it is a Schedule II controlled substance, so there is risk for addiction, dependence, abuse, those types of things. Something we absolutely have to monitor for. Certainly have seen thefts reported, those type of things out in practice. Definitely got to make sure to educate our patients about those risks and people getting access to those medications that shouldn't have access to those medications. From a dosage form standpoint, the two primary dosage forms that you're going to see in practice is immediate release and extended release. Immediate release, historically referred to just as Adderall. Extended release is Adderall XR. With the dosing, it doesn't vary too much between the immediate release and extended release. Immediate release, we might start at a little lower dose, and there is potential that we might do 2, maybe even potentially 3 divided doses. I can't say it's been any time recently that I've seen 3 divided doses, but it is mentioned, I believe, within the package insert there. So one of the biggest things with that dose later in the day, and I'll talk a little bit more about adverse effects coming up here, but, as you can imagine, with norepinephrine, increase in dopamine, that could potentially increase the risk for insomnia. So giving that stimulant type medication too late in the day can definitely cause issues with insomnia. So pay attention to that. Ask about sleep, how patients are doing that way. And for giving 2 divided doses with the immediate release, for example, or maybe we're giving the extended release too late in the day, that's a situation where that could impact insomnia and make that sleep worse. Pediatric dosing in ADHD, usually we're going to start in the 2.5 to 5 milligram dosage range. Again, kind of depends upon age, that type of thing. In adults, we may start more in the 5 to 10 milligram range. Again, kind of depends upon what we're trying to do, maybe past history, all that sort of stuff. The dosage range is pretty similar for both the immediate release and extended release, kind of in that 10 to 40 milligrams per day dosage range. On rare cases, you may see up to closer to 60. Probably more, adult, older patients, obviously, that may be able to tolerate that. But as you escalate those dosages, you probably see more and more adverse effects in that situation. So, again, usual range you're probably going to see in practice is usually in that 10 to 40 milligram per day range. Be a little careful with renal function. Usually if we're using it for ADHD, it's typically going to be for younger patients. So, running into renal issues in younger patients definitely isn't as prominent as older patients. But if you get a patient with creatinine clearance less than 30 mils per minute, for example, we may need to look at that dose and adjust accordingly, adjust downward. All right, getting into the adverse drug reaction. So first one I'll mention, I alluded to already, is insomnia. Got to be really, really careful with the timing of the dose. Many patients taking this medication for ADHD, obviously they go to school, potentially work if they're a little bit older. We want to make sure that medication is on board, during that school day, and we want that medication to turn off later on in the day, so we don't cause too much insomnia. Other things associated with it, anxiety, dry mouth, headache. Those are probably some of the more common ones. There are plenty of risks with stimulants, with this medication specifically as well. First and foremost, I think about cardiovascular risk. Anytime we use a stimulant, anytime we're increasing norepinephrine, that can raise blood pressure, can impact pulse and raise pulse as well. Heart attack, MI, has been reported in rare cases. Again, this is probably a dose-dependent effect. The higher the dose, the more often we use the medication, the higher the risk. If you've got patients with previous cardiac issues, QTC prolongation, structural issues, anatomy changes that are abnormal, that may put a patient at higher risk for some of those cardiovascular complications. Growth is a question I've definitely tackled in practice. Do stimulants inhibit growth? How much do they inhibit growth? That type of thing. So the stunting of growth is definitely reported. It's shown in the literature. The significance of that, how much it causes, that's a little bit more of a variable question. Longer duration, so if you have a patient that started on stimulants at the age of 5 or 6 and they've been on it for 5-10 years, throughout many of their years, many of their growth years where the most significant growth happens, that's definitely a situation where we're probably more likely to see that stunting of growth. So again, longer duration, higher dosages, and coupled with that stunting of growth, you got to recognize that stimulants can reduce appetite and lead to potential weight loss, or in the case of pediatrics and growth, maybe inappropriate weight gain, as patients get older and that type of thing. So that's something that we're going to want to pay attention to and monitor. From a psychiatric standpoint, when we think about stimulants, amping patients up, we can increase the risk for aggression and psychosis. So that can definitely be a challenge, definitely something that you're going to want to look out for there as well. Probably less rare. I don't put it too high on my list of things to pay attention to, but has been reported. Serotonergic issues, increased risk for serotonin syndrome. So kind of summing up some of the major risks, things that you're probably likely to be tested on board exams. From a monitoring parameter standpoint, I'm looking at cardiovascular, so pulse, blood pressure, possibly EKG. And then pediatric patients, we're going to look at height, weight, those type of things, as well as potentially intake and appetite. All right, a little bit on pharmacokinetics. So the immediate release tablet duration of action is in that neighborhood of 4 to 6 hours. So probably the biggest thing to pay attention to is if we're giving a second dose, making sure that that dose doesn't get too late in the day. So if you give that second dose at 2 p.m., 4 p.m., that might be pushing it where, we're causing or maybe some contributing to some insomnia type adverse effects there and keeping patients up at night. So keep tabs on the timing of that second dose. Again, there's possibility to do a third dose. Again, it's been a really, really long time since I've seen that. But just something of note there with that. The Adderall XR, or extended release formulation, that duration is in the neighborhood of 8 to 12 hours. So again, making sure that, we're probably giving this in the morning, which is definitely most common before school, that type of thing. That should cover them for the day and, hopefully obviously not wear off, but hopefully wear off soon enough in the evening where we're not causing insomnia there. Absorption, I did want to mention that. Food typically doesn't affect absorption too much, but there are some stomach acid conditions that can alter absorption. So I'm going to talk a little bit more about that in drug interactions, and that pH of the stomach can cause some issues and some changes with absorption there. All right, let's take a quick break from our sponsor, and I'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study material like NAPLEX, ambulatory care, BCPS, BCMTMS, geriatrics, go check out meded101.com/store. We've helped thousands of pharmacists pass their board exams, and we can absolutely help you too. So go check that link out, meded101.com/store. In addition, if you're a nurse, med student, another healthcare professional taking pharmacology courses or need to know pharmacology better for your work, go check out meded101.com/store. We've got Amazon books there, case studies, clinical pearls, drug interactions, lots of real-world stuff within some of the books that I've created. So go check that out, support the sponsor, help keep this podcast free and available for all to benefit from. All right, so finishing up with drug interactions. I did want to mention a couple of disease states. So bipolar disorder, so if you see a patient on lithium or another mood stabilizer and they have bipolar disorder, stimulants can absolutely induce mania-type symptoms. So got to be really, really careful with a medication like Adderall in that situation, because we definitely have the likelihood of kind of counteracting that mood stabilizer and inducing mania. Again, pay attention to that. The other disease state I wanted to mention was seizure disorder. There is some potential evidence that it can lower seizure threshold. Obviously that risk goes up when we use it with other medications that lower seizure threshold. Bupropion probably being the primary example that comes to mind there. But I think that is something to take note of. If you see a patient on multiple seizure medications or seizure medications in general, I guess, and maybe they have frequent seizures, we probably better at least look at that stimulant type medication and make sure that isn't worsening that condition. All right, next drug interaction I wanted to mention is CYP2D6 inhibitors. So any medication that inhibits this enzyme can potentially increase the concentrations of Adderall. Okay, so important to note that we may encounter more risk for adverse effects like tachycardia, increased blood pressure, insomnia, if we use a CYP2D6 inhibitor with this medication. A couple examples: paroxetine, bupropion, both can inhibit CYP2D6 and may raise those concentrations. All right, I alluded to food, diet, supplement intake, and in relation to stomach acid. So, drugs that raise stomach pH, that would be equivalent to lowering the amount of stomach acid. So, PPIs are a great example here, where they're going to raise the pH, they're going to block stomach acid production, essentially. So, drugs that raise stomach pH may increase the absorption of amphetamine derivatives like Adderall here. Okay? So, PPIs may increase the absorption of amphetamines like Adderall. Now, on the flip side, a more acidic environment can lead to reduced absorption in the stomach and GI tract. Okay? So, a supplement like vitamin C is acidic by nature. Or if you've got a patient that does acidic foods or juices while they take their medication, that could potentially reduce absorption of this medication and ultimately increase the risk for treatment failure there. All right, last but not least, I do want to mention serotonin toxicity. I alluded to that previously. Obviously, drugs with serotonergic activity. There could be a potential enhancing of that activity. SSRIs, TCAs, so on and so forth, could potentially have that additive serotonergic type activity. I would say, and I want to point out, you'd be potentially even at higher risk if you use an SSRI like paroxetine that can actually inhibit CYP2D6, which is an enzyme that helps break down that medication. And it has serotonergic activity on top of that. So, increasing the concentrations and the activity of Adderall, as well as having, serotonergic activity itself, that may lend a little higher risk on the serotonin toxicity scale. All right, well, I think that's going to wrap up the podcast for today. Do me a huge favor, leave a rating review on iTunes or wherever you're listening. Support sponsor, meded101.com/store. All your purchases there go directly to help support this podcast. And of course, reach out to me, mededucation101@gmail.com. If you got any questions, concerns, suggestions, I definitely do my best to try to read every email. If you want to connect with me on LinkedIn, you can do that as well. Eric Christensen, PharmD, BCPS, BCGP. With that, I'm going to sign off. Thank you for listening. Take care. I hope you have a great rest of your day.